He is the founder director at Children's Anaesthesia Services. He is a consultant at Nanavati Breach Candy Surya Holy Family Holy Spirit Wokard Fortis Hospital. He was treasurer and organizing committee member of ASPA 2018 and organizing committee of RO 2018. He is the program coordinator of Paediatric Anaesthesia Fellowship. He has done more than 10 publications in national and international journals.
Very good morning, everyone. At the outset, I would like to thank the organizers for calling us all here. We'll start with the topic, premedication in children. This is my topic for today, is secrets of making pediatric anesthesia fun. So what is premedication? In an operation theatre, whom are you dealing with? You are not dealing only with the child. You are dealing with the entire family. We have to remember that you are not just premedicating the child, you have to deal with the entire family. So what are the goals of premedication? We start with the goals. First and foremost, we all know that the primary goal of premedication is to alleviate preoperative anxiety. Now everyone is anxious. You are anxious, the child is anxious, the parent is anxious. So you have to alleviate the anxiety of everyone who is there in the operation theatre, who's there in the waiting area. Then one of the most important goals in pediatric anesthesia is you have to remember that children don't allow to take IV lines. So mask acceptance is something which the child should allow. So you have to make the child ready for mask acceptance. We'll cover that when we cover throughout the day. We will be dealing with how mask acceptance can be improved. And there are a lot of post-operative behavioral changes in non-premedicated children. So you have to avoid this post-operative behavioral changes. So as we discussed, there is stress everywhere. Also, studies have shown that in non-premedicated patients, there is a higher incidence of emergence delirium, when the analgesic requirements are far higher, and there are a lot of negative behavioral outcomes even in the post-operative period. Like children go through a lot of post-operative stress disorders like bedwetting, altered sleep if they are not premedicated. So in the pre-op visit, your pre-medication starts right from the pre-op visit. You have to develop a rapport with the child and the family. Now there is a difference between these two. Now this is everyone knows this is a rural setting, a poor socio-economic background child, and this is from a rich background child. Now there is a lot of difference in the anxieties of these children. People from the poor socio-economic backup, generally they are not very anxious. Even the parents, the only thing they'll ask is, "Badu saru thai jase ne." That is the only thing they will ask. So you have to just assure them that everything will be fine. Whereas if you have this kind of a parent, they would have done Google and they would ask a whole lot of questions. How will the child behave? What kind of pain relief would you give? So managing this kind of patients is actually, this kind of parents is actually very tough. So you have to tell them in details. Also, one thing to remember is these type of parents actually would be the rich type of patients can be taken inside the operation theatre. You cannot take this kind of parents inside the operation theatre. So parental presence, which is a part of the pre-medication, is possible only in the rich socio-economic status. This patient are really not interested in doing all that, and even the children are very cooperative. So there are a lot of studies which have shown nowadays that even parental anxiety is transmitted to children. So it is important that you alleviate the anxiety of everyone. Now this is a grandmother. Now you have to, if they come with grandmother, generally you all know that grandparents generally pamper their children. So children who come with grandparents, generally they need some kind of sedative pre-medication. These are all studies, they are all psychological studies, these are not anesthesia studies. Now if this is a father, now generally the fathers are very practical. If you ask the father even NBM guidelines, he would be looking at the mother, he would not know anything. So generally the fathers, you don't have to counsel a lot, you have to just counsel the mothers and the grandparents. So this is what I discussed. Parental anxiety is a significant risk factor in child's anxiety. So you don't have to just pre-medicate the child, you have to pre-medicate alleviate the anxiety of the entire family. So how to approach the family? So it is very important how you approach the family. First, remember, first impression is the best impression. So your attire should be very pleasing, your attitude should be caring and loving, and your conduct should be very confident. All the parents want to know is whether the anesthetist would be able to deliver a safe anesthesia to their child or not. So this is very important, how you present yourself for the first time to the parents, because we don't see the patients generally in the pre-operative period. So the first visit is the most important visit. Now pre-medication, coming to pre-medication, pre-medication has to be age appropriate. So different age groups children would have different needs for pre-medication. So generally for less than 8 to 9 months there is no separation anxiety. So generally less than 8 to 9 months we don't tend to give any kind of pre-medication. Even it has been shown that midazolam, something like midazolam in extremes of ages, they cause reverse reactions. They actually become more agitated. So even in say an elderly age group and very small children, midazolam actually can be counterproductive. So you don't need pre-medication, one because they don't have separation anxiety, and giving midazolam can actually be counterproductive. So they can just respond to say something like some soft music or gentle rocking the child. That is adequate for a small child. So now this age group 9 months to 3 years, they generally have a lot of separation anxiety and stormy induction is likely. So sedative pre-medication is very important, and also some kind of distraction techniques which we will discuss now are very important. Now 3 to 12 years generally they need some kind of pre-medication because they understand a lot. They need to feel in control. So you need some kind of pre-medication in these children. Now adolescents generally you may or may not pre-medicate. Sometimes some patients are very cooperative. They can just directly allow an IV line. Some patients may need a pre-medication or a sevoflurane induction before taking an IV line. So you have to be patient specific when it comes to pre-medication in adolescents. The troublesome patients are the patients with some kind of mental disorders or say syndromic children. They are always fearful, they are suspicious of strangers, and developing rapport with them is very difficult. Now this is the patient group where parental presence inside the operation theatre may actually help, because they are more used to managing the child. So besides the sedative pre-medication, even parental presence is very important in these kind of children. So now coming to techniques, there are 3 basic techniques in pre-medication. First is, we all know this, sedative pre-medication. Second is the parental presence. And a number of now newer therapies like behavioral therapies have come up nowadays, which have been encouraged for pre-medication, which we'll discuss in the lecture. So in sedative pre-medication, the drugs that we commonly use is midazolam. Then we have those alpha-2 agonists like clonidine and dexmedetomidine, which are fast replacing midazolam, or they have a comparable efficacy to midazolam. Then you have ketamine, which is an age-old technique of pre-medication. Then others like chloral hydrate, fentanyl, antihistaminics have been used. Another new drug that has come up nowadays is melatonin. Melatonin is one drug that we will discuss now. So melatonin has come up in as a new drug in pre-medication. Also atropine I will categorically say, unless you are using ketamine regularly, atropine has no role nowadays in current era of pediatric anesthesia practice. So please don't use atropine in any form in pediatric patients. They cause a lot of throat irritation and it can actually be bad for the child. So midazolam, as we all know, is the most widely used and considered by many as the gold standard pre-medication. It has a rapid and reliable onset. It is preferred because it has minimal respiratory depression. It also causes antegrade amnesia, so the child doesn't remember when he is taken inside the operation theatre. So the behavioral changes are minimal when you use midazolam. Also, this is a query sort of thing. Reduced emergence delirium is seen with midazolam, but as we discussed, if you use midazolam in the extremes of ages, then it actually causes more agitation. So midazolam, as a measure to prevent emergence delirium and also as a measure to treat emergence delirium, is actually not very proven thing. So emergence delirium is not very well treated with midazolam. It actually causes more agitation in certain patients. So this is a sort of we don't know kind of thing. So what are the routes available? The most common routes are 2 routes: oral, nasal, and IV. IV if you have an IV line. If you don't have an IV line, then of course you have to use oral and nasal. So the doses are 0.5 to 1 milligram per kg for midazolam. Generally we use around 0.5 to 0.75 milligram per kg. The onset is around 30 to 45 minutes. If you are using nasal medicines in any form, dexmedetomidine, midazolam, remember that it has to be preservative free. Otherwise it causes a lot of nasal irritation. Never use any medicines with preservatives inside the nose. For IV, the dose is generally around 0.05 to 0.1 milligram per kg. Generally, we give around 0.1 milligram per kg. The onset is very quick, 1 to 3 minutes. Rectal, sublingual generally are not used, but nowadays you have those midazolam sprays, which are aerosolized sprays. So they can be used to spray sublingually. They are very well absorbed. So those sprays can be used via the sublingual route. The onset is much faster. So it's around 10 to 15 minutes. So any private practitioners here, very little time to take the patient inside. We are worried about your next case, then sublingual route can be used for a fast pre-medication. So what are the drawbacks of midazolam? Many don't consider it as a gold standard. It has a prolonged effect, may not be able to use for daycare surgeries. There are paradoxical reactions, as we discussed, like restlessness and agitation, which can be seen in certain patients. So the newer drugs which have now come up are clonidine and dexmedetomidine, of which dexmedetomidine is the more specific drug, so that is more commonly used. We use it very commonly nowadays. The dose for clonidine is around 2 to 4 microgram per kg, generally is Western literature. For Indian patients, you need a much lesser dose. It is around 1 to 2 microgram per kg. For nasal, it is half the dose. What we have seen is with alpha 2 agonists, the onset time is much later, so it's not the same as midazolam. It actually takes a longer time with alpha 2 agonists. And for dexmedetomidine, it is nasal route, always preservative free, and the dose is around 1 microgram per kg, and you have to wait for at least 45 minutes before you can induce the child. If you take up the child, say in 30 minutes or so, they are not very well pre-medicated. Unlike midazolam, it takes a slightly longer time. So this was a meta-analysis. This is a 2017 study published in Canadian Journal. This was a meta-analysis comparing all studies which are related to midazolam versus dexmedetomidine. So what they have shown is, with midazolam, the onset is much faster. The dexmedetomidine, the onset is much slower. Parental separation is better with dexmedetomidine. That is what they say. That is not our experience. But generally, if you wait for say an hour or so, then with dexmedetomidine, the parental separation is good. Mask induction is similar with both. They tend to accept the mask in a similar fashion with both the medicines. Rescue analgesics, the need for rescue analgesics is much lesser with dexmedetomidine. It is needed with midazolam, obviously, because it has some pain relief properties which we all know. Emergence delirium, they say, is similar. In our experience, we have seen that with dexmedetomidine, the rate of emergence delirium is much lesser. Nasal irritation is seen with midazolam. If you use intranasal midazolam, it is not seen with dexmedetomidine. Chances of post-operative nausea vomiting is lesser with dexmedetomidine. Only one drawback of dexmedetomidine is the heart rate and BP is sometimes lesser, which may be a problem, especially in very small children which are heart rate dependent, which have a heart rate dependent cardiac output. So we generally don't give them pre-medication, like for say a child less than 6 months or so, we don't give them dexmedetomidine because the heart rate can be troublesome for us. Now ketamine is an age-old technique. We don't use it nowadays, but it is a very good drug for occasional pediatric anesthetists who like to take IV lines awake. We generally do inhalational inductions and then take IV lines. So if you like to take IV lines awake, then you have to combine midazolam with ketamine in a dose of around say 5 to 6 milligram per kg orally. IM ketamine is reserved. This is my next slide. If you are using IV ketamine, the dose is around 1 to 2 milligram per kg. In fact, nowadays there are a lot of studies which say that you have to use ketamine regularly in a dose less than 1 milligram per kg. In between, there was a time when they used to say that ketamine should be avoided because there is chances of neurotoxicity. Now they say that in a dose of less than 1 milligram per kg, ketamine is actually useful and it actually reduces the chronic pain component of surgery. So you have to use ketamine in a dose of less than 1 milligram per kg. But it is being replaced as a pre-medicant because there are better agents available and it causes a bit of emergence delirium and delayed recovery. Now IM ketamine is a drug which is very seldom used, but you may have to use very rarely, like for if you have a very hyper child with say ADHD, not responding, not accepting mask, you don't want to restrain him, he's a very uncooperative and combative children. This is your last resort. It should not be used as a routine. It can be used only as your last resort in a dose of around 3 to 5 milligram per kg. This is just a slide I have put. Please don't you practice it regularly, but this can be used as a last resort in specific scenarios. Now other drugs are oral transmucosal fentanyl, which is not available in our country. It is available in Western countries. Antihistaminics can be used. Chloral hydrate is a common drug which hardly ever acts. I have hardly seen it act, so we don't use it. Midazolam is a far better drug than chloral hydrate or pedicloryl that we use. And the new drug that has come up nowadays is melatonin. So what they have found is melatonin was useful in the treatment of sleep onset insomnia and delayed sleep phase syndrome. So they thought that melatonin can be used as a pre-medicant in anesthesia practice. So now a lot of new literature is coming up with pre-medication with melatonin versus midazolam. So the dose of melatonin is around 5 milligram per kg orally. It is available as tablets. This is commonly available on Amazon. It's around 600 rupees for some 60 tablets. So it's around 10 rupees per tablet. So what we do generally is we calculate the dose around 5 milligram per kg. We mix it in some syrup. Generally the syrup that we like to use as in pre-medication is crocin syrup. So in a dose say 10 to 15 milligram per kg, crocin syrup is a flavored syrup. So in a dose of say 10 to 15 milligram per kg of with paracetamol, you dilute the melatonin and you can give it to the child. Other syrups that you can use are your sharbat, any type of sharbat, honey, ruh afza, all this can be used, but we prefer to use crocin syrups. Atropine, as we discussed, has no role in pre-medication. Only if you are using oral ketamine, then maybe you want to use atropine. Atropine causes, especially in tropical countries like ours, there is no role of atropine. So this is a child, this is around so this is a child who is pre-medicated. So he is coming up with a toy, he is pre-medicated. You can see how without the parent, he is just a bit confused and he is coming inside without crying. So this is the level of pre-medication we want. This is a child who would accept a mask easily. Maybe he will not allow an IV line, but he will definitely accept a sevoflurane mask very easily. So this is this child was given around 5 milligram per kg of 0.5 milligram per kg of midazolam orally, and after say 30 minutes or so he was wheeled inside the operation theatre. Now coming to parental presence, there was initially a time in the early 2000s where there were a lot of studies which showed that the parental presence inside the operation theatre can cause a lot of decreased anxiety in children, but it very much depends on the anxiety levels of the parents. So most of the studies nowadays have shown that there is no added advantage of parental presence inside the operation theatre. Routine PPIA or parental presence intraoperatively does not confer any benefit. This is what most of the meta-analysis say. We have also seen parents collapsing inside the operation theatre. We don't like to take parents inside the operation theatre routinely, but if they are taken inside, parental satisfaction in patients who are not anxious, in parents who are not anxious, is actually better. So this was a study, this is a 2006 study which they have shown, where they have studied which kind of parents would be helpful inside the operation theatre. So they found that PPIA is useful only in calm parents, in children with chronic illness. So if you have a child with say cerebral palsy or a syndromic child, they are much better used to managing the child inside the house. So in these kind of patients, parental presence is very useful. In children with chronic illness or patients who have undergone previous surgeries or who have done multiple perioperative encounters, only in those children, parental presence is actually useful. Now coming to the third part which is coming up nowadays is behavioral interventions. This is gaining prominence nowadays. The target is both child and parent. So what are the behavioral interventions that are available now? There are video games, there are interactive computers, then there are certain pediatric hospitals which have clowns which come inside the operation theatre and they try to alleviate the anxiety. Then hypnosis has been tried, acupuncture has been tried. There are a lot of web-based programs nowadays both for parents and child which try to encourage them, they show what the operation theatre is, what they can expect inside the operation theatre. So a lot of material is available. Now this is one intervention which is taken prominence nowadays. It is called as tablet-based interactive distractions. Nowadays everyone has a mobile phone. So tablet based interactive distraction or allowing the child to play something. So a smaller child can be played some music or some games or something. Interactive kind of tablet helps in relieving anxiety, and it has been shown that it is as effective as midazolam if done properly. This is a 2013 study. So they have also studied what all games children like to play according to the age group. So something like say Angry Birds would be useful in a child of say 4 to 6 years. Then something like a talking tomcat can be very useful in a smaller child. So they have shown which games are useful in which kind of age groups, and they are it really helps in alleviating the anxiety. So this is a British Psychological Society study which they have shown that the measures which help in reducing anxiety are cognitive behavioral approach. There are a lot of distraction techniques like tablet-based interactive distractions, a child-friendly environment, developmentally appropriate play materials are very useful besides sedative pre-medication in relieving the anxiety. The only disadvantage of these kind of techniques are they are time consuming and they may be costly, but they are not costly nowadays because everyone has a mobile phone and you can always have games or some kind of things downloaded if you are practicing pediatrics regularly, and it can be used to elevate the anxiety. So my conclusion is sedative pre-medication has a well-established role. It has to be used in wherever applicable. Behavioral techniques are gaining importance. Preferably you combine sedative pre-medication with behavioral techniques to have a better outcome. Parental presence is controversial, but parental presence can be used in certain select category of patients like those with chronic illness or who have repeated hospital visits or who come for repeated surgeries. Thank you.
Thank you, Dr. Ankit, for sharing the views. The tablet distraction was the best one. I request anyone to have any questions regarding the topic. Yes, yes, sir.
Dr. Ankit, can you do you recommend Hello. Do you recommend atropine or glyco when you are using scoline or not?
Generally, if you are using repeat scoline, then you may have to use, but nowadays the role of scoline in pediatric anesthesia is very much reduced. Like the only place, like I would never do a case without having scoline on my workstation, but the only place where I would use scoline is something like a laryngospasm, very severe laryngospasm. So it is not a routine thing. So nowadays we don't use scoline, that's why we are not using glycopyrrolate and atropine. So if you are using repeat doses of scoline, like say in a bronchoscopy or something, then you should use atropine.
Okay, thank you.
Yeah.
One more question. While adding ketamine, we are not going to give it, but do we add glyco or atropine with it in the same syringe?
No, we don't add it.
You
we
don't
give
add
it during the pre-medication.
Okay.
But after taking the IV line.
Okay. Thank you very much.